Hello friends, I am back and this time I am going to revise the gynae cancers. Okay, I'm going to touch upon all the gynae cancers. I'm going to talk about cervical cancer and ovarian cancer slightly more in depth as compared to the other gynae cancers. Since these are the two cancers which most often are being asked in your recent NEET PG, INI-CET as well as FMG examination. So this rapid revision session is in continuation with the last LRR that I took on the YouTube, right? So supplement this in addition to what we have already done in the LRR sessions earlier. Like for example, postmenopausal bleeding clinical approach, postcoital bleeding clinical approaches, these have already been discussed in the previous LRR sessions, all right? So let's get started and have a look at the first question. Now there's a 35-year-old sexually active woman who visits the gynae OPD for routine checkup. She's concerned because her mother died of cervical cancer. So she has a family history of cervical cancer. At the age of 40 years, that mother died. What would you advise her, right? So please remember here the examiner is asking you whether or not there is any genetic basis to cervical cancer, considering that she has a history of cervical cancer in the family, right? So the answer to this question is no, cervical cancer has no genetic basis, right? It doesn't run in the families. The risk factors of cervical cancer are entirely different if you compare them with endometrial and ovarian cancers, right? So hereditary gynae cancers which runs in families, then we are mainly talking about endometrial and ovarian cancer, not cervical cancer, right? So BRCA testing, HNPCC testing, it is not associated with cervical cancer. So this is not your answer, right? Now the other two options, whether we should go for vaccination or whether we should go for screening, right? So primary modality for early detection of cervical cancer, and that is one strategy of prevention for cervical cancer, is screening, right? Then you would ask, why not vaccinate this 35-year-old woman? Well, she's not at the appropriate or primary target age group for vaccination. She's already been sexually active also. Now, I'm not saying that sexually active women cannot be vaccinated. I'm not saying that, all right? So they can be vaccinated up till the age of 26 years. Beyond 26 years, it's only case-to-case basis. Only in certain high-risk women is even, HPV vaccination even considered, right? So one reason is that. And the other reason is that even if we vaccinate a woman, right, she still has to get herself screened. Okay, so screening is the primary modality here. From this question only, keep in mind and make a side note that HNPCC mutation, right, the one that is what we call as Lynch 2 syndrome, right? So whenever a woman is carrying this mutation, the lifetime risk of endometrial cancer, is about 40 to 60%. And that of ovarian cancer is about 10 to 12% in those who are carrying this mutation. Right? So these mutation carriers, they can be offered, screening with endometrial, aspiration for endometrial cancer, or for with the transvaginal sonography for potential ovarian cancer, but only in mutation carriers. Okay, from age 35 onwards, there's an option of risk reducing surgery also once their family is complete. So at least keep this much in mind. Now, as long as about BRCA1 mutation is concerned, BRCA1 mutation is associated with risk of ovarian and breast cancer. So I'll talk about ovarian cancer here. The lifetime risk of ovarian cancer with BRCA1 mutation is about 45%, and with BRCA2 mutation, the lifetime risk of ovarian cancer is about 25%. Okay, so these are extra pointers. Make a side note, keep them in mind. Now, let us also recall some of the important pointers about cervical cancer. So, remember, cervical cancer is the most common gynae cancer in Indian women, and it is most commonly associated with HPV 16. This is a one-liner question. Please remember that, right? Human papilloma virus. However, if they ask you the most specific, it should be HPV 18. So HPV 16 and 18 together account for about 70% of cervical cancer cases. Okay. However, if you have to pick one, pick HPV 16 as the answer among the two when they're asking you most commonly associated. Now, the HPV type that is also associated, actually with warts and condyloma acuminata, right? These are warty lesions, and these are the low risk HPV DNA types, which is HPV 6 and 11. Now, oncoproteins which are required for viral replication. Now, see, high-risk HPV DNA, they infect the squamous cells of the cervix, and what happens is that the HPV DNA gets integrated into the host genome, and oncoproteins needs to be synthesized. And these are the oncoproteins which are ultimately going to result in change of the cells to, dysplasia and then finally to malignancy. So, oncoproteins for viral replication, please remember, is E1 and E2, and oncoproteins required for malignant transformation of the cells is basically E6, which targets the P53 gene. P53 is a tumor suppressor gene. So, these oncoproteins target those tumor suppressor gene, and E7 that targets the RB gene. Right? Now, they also ask you what is the most common histological type. So, I hope you recall that cervical cancer can involve the ectocervix, and the region on the ectocervix is the transformation zone we are talking about, where cervical cancer and CIN as well most commonly is found. Transformation zone on the ectocervix, right? The area between the old and the new squamocolumnar junction. That's the transformation zone, right? So, there the epithelium is squamous epithelium, stratified squamous epithelium. So, most common histological type is also squamous cell cancer, and that too large cell keratinizing type. Okay, but please also remember, it doesn't mean that cervical cancer cannot arise from the glandular epithelium. Where will be the glandular epithelium? The endocervical epithelium. Okay. In fact, now we're also seeing increasing incidence of cervical cancer arising from the endocervical epithelium, and that we call as adenocarcinoma, right? The incidence of adenocarcinoma, particularly in OCP users, young women, is now increasing. Okay, but still the most common histological type is squamous cell cancer. So, adenocarcinoma is associated with OC pill use, remember that, and in younger women, and also very specifically associated with HPV 18. Remember these 3 points about this adenocarcinoma histology as well. Now, also remember the risk factors for cervical cancer, right? So, cervical cancer, again, the causative agent is HPV. How is HPV acquired? By sexual intercourse, right? So, early intercourse in childbirth, high parity, low socioeconomic status, multiple sexual partners, that is also important to note, that the chances of acquiring HPV infection increase when a woman is also having concomitant sexually transmitted infections or HIV infections, and a lower immune status, immunocompromised state. These are all risk factors for cervical cancer. Now, very important to remember, if you look at smoking, okay, if you look at smoking is particularly a risk factor for squamous cell cancer histology. And like I said, oral contraceptive pills, they are a typical risk factor for adenocarcinoma of the cervix, as I specified earlier. Okay, so these are some key important pointers you need to remember. Now, let's also talk about HPV vaccination, because I told you that vaccination is also a preventive strategy against cervical cancer. This would be a primary prevention for cervical cancer. But what are the recommendations for HPV vaccination in the population? This you want to know. So, first of all, we have the quadrivalent vaccine, Gardasil as well as Cervavac, right? Now, Gardasil is the foreign brand and Cervavac is the indigenous brand of quadrivalent vaccine. And it contains basically HPV 16, 18, 6 and 11 strains, right? And then we have Gardasil S also, Gardasil 9 also. This is 9-valent vaccine which contains the above 4 strains plus the other high-risk HPV type strains are also there. Remember that HPV vaccine is an inactivated vaccine made up of virus-like particles, L1 capsid protein, composed of L1 capsid protein. Okay. Now I told you, please remember that the recommended age is for girls 9 to 26 years of age, right? So when I say 9 to 26 years of age, please remember that the primary target age group, primarily the target age group, this is very, very important, is the ones between 9 to 14 years of age. Okay, 14 to 26 years is the secondary target age group, meaning catch-up vaccination can be done in those 14 to 26 years of age. Beyond 26 to 45 years of age, it is on case-to-case basis. So for undergraduate level, you should at least remember 9 to 26. Primarily 9 to 14 years of age is the primary target age group. Okay. Now, what is the dosage schedule? Between 9 to 14 years of age, 2 doses. Okay. 0 and 6 months, basically. And more than 15 years, 3 doses, 0, 1 to 2 months and 6 months. Okay. It's given as intramuscular injection. It's a 0.5 ml vial. Okay. Now, certain important pointers like WHO gave this recommendation in 2022. These are the SAGE recommendations. They have not been adopted by the Government of India guidelines so far, but once INI-CET had asked a question on particularly SAGE recommendations, it has not been repeated after that, this question on SAGE recommendations. So I'm just mentioning that they are saying that, the dosage schedule can be a bit more relaxed in the sense that 9 to 20 years, 1 or 2 doses, and more than 21 years, 2 doses should be good enough to give sufficient immunity. That's all. But for now, what we are following is the dosage schedule that I have mentioned. This is also followed by the Indian Academy of Pediatrics. Okay. Now, certain other important pointers, like I already emphasized, that vaccinated women, they need to continue to get themselves screened, right? So somebody is getting vaccinated now or has gotten vaccinated earlier, but now is falling in the age group in which screening is done. Screening should also continue. It's not like you get vaccinated and you forget about screening at all, right? Now, can sexually active women get vaccinated? Yes, they can get vaccinated, and there's no recommendation of doing the HPV testing before initiating vaccination. And please, this vaccination cannot be given to pregnant women. No, it is contraindicated in pregnancy. If accidentally one has given to a pregnant woman, then it's not an indication for termination of pregnancy, right? So if accidentally one has given to a pregnant woman, don't give further dosages. Okay, then the rest of the schedule will be completed once the pregnancy is over. Now, what should you know about cervical cancer screening? Okay, now the most important thing that they are asking you in examination these days is the WHO guidelines on cervical cancer screening. Okay, so the concept of screening, like I told you, screening is a method of secondary prevention. That means, yes, early diagnosis and treatment, and screening is recommended for apparently healthy women, right? Now, the age group screened is generally, it is, if you look at from the ACOG perspective, ACOG guideline, it is 21 to 65 years. Okay, this is what the ACOG says. Okay, so reproductive age group women up till the age of 65 years also, they are screened. Okay, now please remember that in India, we are not generally screening such young women. We are screening from 25 years onwards. Okay. Now, the WHO says that what is the priority age group for screening? This is what you need to remember. Priority age group for screening, this is what you need to remember, is 30 to 49 years as per WHO. Okay. And WHO says that primary HPV DNA testing is recommended once you decide to screen beyond 30 years of age. It is HPV DNA testing. Primary HPV DNA testing meaning we're only screening with HPV DNA testing. That is what the recommendation is. Okay. Now, the other thing that, is done as far as screening is concerned is co-testing. Now, co-testing means, just make a side note what co-testing means. Co-testing means doing HPV DNA testing plus PAPs at the same time in the woman. Okay, doing co-testing, doing these two tests together as a part of screening. Now, when we do these two tests together, what does it do? It also adds to the cost of the screening, isn't it? So that is why WHO is not favoring co-testing. WHO is saying primary HPV DNA testing. A lot of private centers in our country also are still going with the co-testing. Co-testing is recommended by ACOG American guidelines. Okay, WHO has changed its stance a little, saying co-testing is not a very reasonable, cost-effective approach when we have good primary HPV DNA testing available. But at least, yes, you should know that if HPV DNA testing or co-testing is done, it is to be repeated every 5 years, right? If PAP or cytology is done, according to WHO, PAP is also acceptable. It is to be repeated every 3 yearly. And VIA is also acceptable by WHO. If VIA is done, then it is repeated every 3 yearly. And stop the screening at the age of 65. 65 is given by ACOG. WHO for this is saying 50 years. That is the change with WHO, right? So stop the screening if regular screening has been there in the last 10 years. Okay. Now also know what is about the screening in low resource settings. Okay. So there are two tests which can be done in low resource setting. One is visual inspection with acetic acid. The other is an affordable primary HPV DNA testing wherever available. This is what WHO is saying, and WHO is favoring primary HPV DNA testing kits that should be made available even in low resource setting. Right? So that is one strategy that the WHO is saying. But if you look at the Indian context, in our peripheral healthcare centers, community healthcare centers, as of yet, these HPV DNA testing kits, the affordable ones from the government supply, they are not there, right? So we still depend on VIA, visual inspection with acetic acid, for screening in our low resource settings, right? So keep in mind these two very, very important points regarding screening in low resource setting. Both are fine, VIA and primary HPV DNA testing. Both are applicable by WHO. WHO promotes primary HPV DNA testing, but as of now, in our country, we are primarily dependent on a visual inspection with acetic acid in our low resource settings. Okay, but both are fine. Now, identify these images as far as screening is concerned. See here, cervical cancer screening. This is Ayer's spatula, okay, to take the cervical smear sample from the transformation zone. This here is the liquid-based cytology kit, okay, and this one here image is the, you can see this brush here, cyto brush, and this is a slide. Okay, so we take the Ayer's spatula to take the sample from the ectocervix. We use the cyto brush to take a sample from the endocervical canal, and with the help of this, when we make a slide, we immediately put the slide in the fixative. We don't let the slide air dry. We immediately put in the fixative. It's a box filled with fixative. We cover it and send it to the path lab to be analyzed. So this is basically the conventional pap smear technique. Conventional pap smear technique. Okay, fine. When you make the slide yourself in the OPD, when you are taking the sample. With a liquid-based cytology kit, we are taking the sample, but we are putting this brush, dipping this brush inside the fixative and just swishing it like this. Okay, so the cells get dispersed, right? So basically, if you look at these two methodologies of processing the sample, both are cytology, but just the method of processing the sample for making the slides is different. Okay, now with liquid based cytology kit, the fixative is methanol. They ask you this question, remember this, fixative is methanol. And with the conventional pap smear, like I told you, slides are not allowed to air dry, and the fixative is 95% ethanol. Okay, the advantage of liquid based cytology is that lesser number of unsatisfactory smears are achieved, and the same sample can be used for HPV DNA testing. These are the two advantages of liquid-based cytology. Also remember, and this is something that you read in your pathology, Pap smear reporting is done by the Bethesda system. Know the name of this system. Like, the Bethesda system gives us guidelines to label the Pap smear reporting as low SIL or high SIL or ASCH or ASCUS, and these various type of epithelial cell abnormalities, glandular cell abnormalities. These are defined by a system of reporting which is called as the Bethesda system. So at least know this. Now, if you look at the next question, okay, we'll just move ahead now from the screening to something else now. Now, a 40-year-old woman with Pap smear report of high SIL. This is high-grade squamous intraepithelial lesion. This is abnormal Pap smear report. She is subjected to colposcopy. So, what will you remember here now? That abnormal screening results will be subjected to colposcopy. Why? Colposcopy allows to do which of the following? Colposcopy allows to see the transformation zone in all the patients. See, yes. When we do colposcopy, meaning that we are visualizing the cervix under magnification. That is what we are doing, all right. We are also dabbing the cervix with 5% acetic acid so that abnormal areas are identified, because abnormal areas are going to turn white. That is done. That is what is done in colposcopy, so that we can have an abnormal area to biopsy. We will also be looking at the entire transformation zone. The entire region of the transformation zone has to be analyzed. But that is the goal. But are we able to see the entire transformation zone all the time in all the patients? No. There is a possibility that the squamocolumnar junction, if you look at it like this, supposing this is the old squamocolumnar junction, suppose, and this is the new squamocolumnar junction, then this is the area of transformation zone that we want to look at. But sometimes this squamocolumnar junction may be going inside the endocervical canal, and we may not be able to appreciate the upper limit or the inner limit of the new squamocolumnar junction. We have to see the new squamocolumnar junction in totality, all around the maybe it is going inside the endocervical canal. So we may not be able to see in all patients. Okay, that happens, especially in postmenopausal women. It's in postmenopausal women, the squamocolumnar junction may be inside the endocervical canal. So we may not be able to see it completely, right? So is it going to treat invasive cancer? No, colposcopy is not treating. Colposcopy is a method of triaging. An abnormal smear is evaluated further by colposcopy, triaged to make a diagnosis and then act upon the diagnosis, not as a method of treatment. Okay. So, now choose between option number B and D. Which is a better answer? See, colposcopy alone will not make the diagnosis of cancer. Think. Okay, colposcopy alone, no. Just by looking at the cervix, you will not 100% say it's cancer, no. You need a biopsy, right? So, cervical cancer will be a histopath diagnosis. So, yes, it will help make the diagnosis of cancer. It will help, but it will be a biopsy that will establish the diagnosis. Biopsy will establish the diagnosis, not colposcopy by itself all alone. So, this is how they trick you, right? So, between B and D, the better answer to choose is B. Choose the most suspicious area on the cervix to biopsy. So, that's the role of colposcopy. So, that is how it will help establish the diagnosis, but it is biopsy that establishes the diagnosis, right? Now, look at these images and let's identify. See, this is an image here which is not magnified, okay? And you can see here that this is an area on the ectocervix, right? Now, see, now everything will become clear. So, this is the new squamocolumnar junction, and somewhere in the periphery must have been the old squamocolumnar junction, and we are able to see the transformation zone completely. This is the abnormal area that has turned white, right? on application of 5% acetic acid. Okay, the principle is the same. When we do this and look at the cervix with the naked eye, it is visual inspection with acetic acid. When we do this and look at the cervix under magnification using a colposcope, now you can see these are magnified images, the same area, only a portion of the cervix is being magnified, the same area. We are able to see now with much more clarity the margins of the white area, any abnormal vascular patterns, over the white area we are seeing. See, this is the white area. Abnormal vascular patterns over the white area we are seeing. So we are able to analyze, so maybe this is the most abnormal area and not this, because abnormal vascular patterns are there over the white area. So this is the advantage of colposcopy, right? So these here on the right, these two here on the right are colposcopic images. Right? So what we can see, we can see abnormal white area and coarse mosaic and punctations, abnormal vascular patterns, coarse mosaic and punctations over the white area. These are abnormal. And what you can also appreciate is that the vascular patterns, they become more prominent using a green filter. Okay, this was asked in FMG also. That's why I'm showing you these images. Okay, now moving on, another important thing about screening modality for cervical cancer, what the WHO says is there are two approaches. There is screen and treat approach, which is more valid in low resource settings. So we can do VIA or we can do primary HPV DNA testing. And if positive, then we can do VIA guided treatment in the same sitting. Okay? And usually it is visual inspection with acetic acid guided treatment, so that we can also, look at the abnormal area. Okay? The other approach is screen, triage and treat approach. Okay, because we don't want to over-treat. So, screen, triage and treat approach. So, let's say we started with HPV testing. Then we can triage. Other tests can be used to only refer the abnormal cases to colposcopy. Like HPV genotyping can be done, so that the high-risk HPV DNA type 16 and 18 types can be subjected to further testing. Or we can triage using cytology or VIA and then subject them to colposcopy depending upon the results of the triage test. The other thing is, let's say we started with cytology. If the cytology is L-cell, atypical squamous cells, cannot exclude high-grade ASC-H, or high cell, then colposcopy is done. Okay, then there is another cytology report which is ASCUS. Why am I telling you this? Because this was a recent INI-CET question. ASCUS is atypical squamous cells of undetermined significance. Okay, now with ASCUS, the option of colposcopy is also there, that one can directly go to colposcopy. With ASCUS, the option of repeating the test is also there. Repeating the cytology is also there. But what is most preferable by us is triage, HPV triage. Okay, so ASCUS with HPV positive, then we generally go for colposcopy. This is the preferred approach to ASCUS. This was a recent INI-CET questions, and that is why we've spoken about it. Okay. Now moving on, let's have a look at the next question. A 30-year-old para-1 live-1 female with pap smear report of high cell underwent colposcopy. Okay, fair enough, because abnormal screening, colposcopy. An abnormal area was also identified on the ectocervix. Biopsy showed dysplastic cells involving full thickness of the epithelium, but the basement membrane is intact. What is the next step? So, What are they asking you? First of all, they are asking you what is the diagnosis. So what is the diagnosis? Basement membrane is intact. The dysplastic cells are limited to the epithelial lining. So this is CIN1. But involving full thickness of the epithelium, this is CIN3, isn't it? So CIN3 is dysplasia that is more than 2/3 of the epithelial to full thickness, I'll just write FT, to full thickness, right? CIN2 is dysplasia involving more than 1/3 to 2/3 thickness of the epithelium, and CIN1 is dysplasia in the lower one-third of the epithelium. So this is what was called as mild, moderate and severe dysplasia. But now the system is CIN system. So I need you to remember the CIN system. Okay. Now CIN2 and 3 together, it is called as the high grade CIN. So they may ask you CIN3. They may mention something like this where it is CIN3, or they may say a woman has been diagnosed with high grade CIN. CIN is going to be a histopath diagnosis. CIN is a histopath diagnosis. Okay, please remember this. High grade CIN has to be treated. Okay, and mainly the treatment is excision. But high grade CIN is still not cancer. So please do not mark hysterectomy as the answer. Okay, it is benign. CIN is pre-malignant. For pre-malignant, no hysterectomy. Whatever be the age or parity of the woman, it doesn't matter. Hysterectomy will not be your answer for CIN. Okay, now the other choices. Cryotherapy is also not preferable. We need, this is high SIL. This is high grade CIN. Okay, this will need excision therapy preferably. Cryotherapy out. Now, how do we excise the cervix? Do we do conization or do we do LEEP? There are only limited indications of removing the entire substance, removing the entire cone of the cervix. Conization is the procedure where the entire substance and cone of the cervix, like this would be conization, removed in the OT under anesthesia with the scalpel. That's why it was also called as cold knife conization. Not that the knife is cold, but the scalpel is used. So conization has limited indications now. The treatment of choice for high grade CIN is nowadays LEEP. What is LEEP? LEEP is loop electrosurgical excision procedures. Okay, fine. And this is what is also sometimes called as LLETS, large loop excision of the transformation zone. Okay, right, this terminology is US UK terminology, that's the difference. But what is being done is that a loop of cervical tissue is removed and electrosurgical principles are used. This can be done in the OPD basis. This is not going to sacrifice too much of the cervical tissue also. So this is the preferred way, right? It can be therapeutic and diagnostic in the same sitting also, with less amount of bleeding that is involved. That's why I said it can be done in the OPD basis. So nowadays, LEEP is the procedure of choice. Remember this much. Okay. Now identify these images. See, these are the electrosurgical loops that are connected to the cautery machine, and this is run over the transformation zone like this. This is electrosurgical loop is run over. This is where the source of the abnormal cells were. So abnormal area has been identified in this location, and this loop of cervical tissue is excised. This is the excisional procedure. This is what we call as excisional procedure. This is LEEP. Okay, what you're seeing below is what we call as cryotherapy. This is the cryo gun. And this cryogun, the tip of the cryogun is put on the, it is put on the cervix like this in a manner that like let's say the nib of or the tip of the this gun actually goes inside the endocervical canal, slightly inside, just touching there. And this, you can see here this ice ball formation, okay, because this is basically, this tubing is connected to a cylinder which contains compressed gas, which is either carbon dioxide or nitrous oxide in low temperatures, and it delivers that freezing energy of these gases to these cervical tissues, and these plastic cells are destroyed by cryo energy, right? So if you remember these images, one thing will become clear to you. One thing will become clear to you, that cryotherapy will become an acceptable alternative only when there is a small lesion, just a small lesion, maybe here, wherever, which is fully covered by the cryotip, and it should be completely on the ectocervix. It should not be going inside the endocervical canal, and there should absolutely be no suspicion of cancer, right? So cryotherapy is only acceptable in these situations. Keep that in mind. This is slightly on a deeper level. For FMG aspirants, you should know what LEAP is, you should know what cryotherapy is, you should know that for high-grade CIN, treatment is preferable. CIN1, one can observe. CIN1, one can observe, and if it persists for 2 years, then we can go for treatment. With CIN1, if we are sure that it is CIN1, then cryotherapy can be used for CIN1 treatment also. But for CIN2 and 3, it is always LEAP. Please keep that in mind. And like I said, there's certain indications of conization when there is a discrepancy between cytology, colposcopy, histopath. Let me explain. Supposing that the cytology said high SIL. Supposing we did a colposcopy, and on colposcopy we found an area, we biopsied, and the histopath came CIN1. Now we are surprised. Why are we surprised? Because it was high SIL, and high SIL should at least corroborate with CIN2 or 3. That is what I'm expecting. So I'm wondering if the colposcopy was done adequately, if the most abnormal area was biopsied or not. So I will review my colposcopy, I will review my histopath, whether the histopath report is correct or something has been missed. After reviewing everything, if there is a discrepancy, then where are these high-grade squamous cells coming from? Are they coming from the endocervical canal? So that would be an indication for conization. If there is a suspicion of microinvasive cancer on biopsy or LEAP, see if the LEAP, that specimen that I had sent, the report comes back in a patient with high SIL, or ASCH, these high grade lesions or these high grade abnormal results, right? If the biopsy or the LEAP report says that there is some doubt that there is microinvasive cancer. What is microinvasive cancer? It's not visible to the naked eye on the cervix, but on histopath, the basement membrane is breached, and there is suspicion about that. So we have to see the entire substance of the cervix, you have to see the entire transformation zone. So this would be another indication for going for a conization. Or there is high SIL, ASCH with unsatisfactory colposcopy. High SIL or ASCH with unsatisfactory colposcopy. Or ECC is positive for CIN2 or 3. ECC is endocervical curettage. Please remember here that whenever we are doing colposcopy, just coming back here, whenever we are doing colposcopy, just coming back here to these images, just mentioning another extra pointer, that when we do colposcopy and we take a colposcopy directed biopsy, ECC or endocervical curettage is not always needed. It is done indications for doing ECC. Okay, while we are doing colposcopy, we are taking a directed biopsy. Okay, when do we do or when do we include endocervical curettage? When there are abnormal glandular cells, Let's say in the pap smear, in the cytology report, there are abnormal glandular cells. Then we will do ECC also, or high SIL or ASC-H is there, and there is no ectocervical lesion. Then we want to look at the endocervix also. Or the transformation zone is type 3. Transformation zone is not completely seen. It is an unsatisfactory colposcopy. These are the situations when we do a endocervical curettage. Now, this is more for NEET PG and this is more for INI-CET level. So, it is slightly more in-depth as compared to FMG level. But please remember this much, that ECC is not always done, but it is indicated as required while we are doing a colposcopy. After we completed the colposcopy evaluation, ECC can be added during the evaluation. So, if that ECC report is positive for CIN 2 or 3, then conization is done, or if adenocarcinoma is suspected, then conization is done. So, these are the 5 valid indications of doing conization. Okay. Now, moving on, let's have a look at the next question. So, we are done with CIN. This is a quick recall of CIN and cervical cancer screening strategies, right? Now, 37-year-old woman with irregular vaginal bleeding is diagnosed with cervical cancer. I have discussed with you now, up till this question, how cervical cancer is diagnosed. I hope it is clear to you. We can reach the diagnosis of cervical cancer via the screening strategies. Screening and on-screening, abnormal paps, evaluation, colpo, biopsy led to the diagnosis of maybe invasive cancer. The other way that we ended up diagnosing cervical cancer is a patient is symptomatic, right? A patient is symptomatic with irregular vaginal bleeding, post-coital bleeding being the most specific complaint of cervical cancer. So, the profile of the patient could be irregular vaginal bleeding or the most specific complaint of post-coital bleeding, and on further evaluation, there may be on evaluation on per-speculum examination, a growth on the cervix which has been biopsied, and it is biopsy proven that it is cervical cancer. So, this is how we approach or we reach to making the diagnosis of cervical cancer. She has a 4 centimeter growth over her cervix and she has also left-sided hydronephrosis. Please remember, whenever cervical cancer is confirmed after taking the biopsy and everything, that it has to be a metastatic workup. That is true for all situations of cancers, whether it is gynae, whether it is surgery. Nobody proceeds with a management, or whether it is surgery, chemo, whatever, or a plan of management cannot be made without doing a full metastatic workup in a case of cancer patient, right? So, after the full metastatic workup, it has been found that the growth is 4 centimeter, it is over the cervix, but also there is left-sided hydronephrosis. What is the most appropriate treatment, right? So, what is this left-sided hydronephrosis telling you? If you just look at the growth on the cervix, you will say that this is stage 1. It is limited to the cervix, but left-sided hydronephrosis with no other medical reason for the hydronephrosis, that has to be eliminated, but obviously it's not mentioned in the question. So, I'll assume that this is because of cancer. Okay, so I'll assume that this is because of cancer, and it is not like cancer has spread to the kidneys. Please don't think like that. Hydronephrosis happens because the cancer spreads to the parametrial tissues, to the lateral pelvic wall. In the lateral pelvic wall is traveling the ureter. It gets engulfed with the tumor deposits here in the parametrium and the lateral pelvic wall, and that is why it is causing ureteral obstruction, and that ureteral obstruction is responsible for hydronephrosis. So, what do we know here? That as and when we see lateral pelvic wall involvement, this is what you need to remember. When you have lateral pelvic wall involvement, what will you see? You will see maybe signs and symptoms of lateral pelvic wall involvement. Obviously, it can be looked up with MRI. But some clinical signs and symptoms will be there, like sciatica-like pain, for example. Right, hydronephrosis, for example. Lymphedema, because the lymph nodes are traveling in the lateral pelvic wall. Pelvic nerves are traveling in the lateral pelvic wall, right? So, if symptoms like this are there, that in itself means it is advanced stage, that in itself is signaling towards lateral pelvic wall involvement. And then there is no role of surgery. No. It becomes inoperable. right? And then, which is a better choice, chemoradiation or radiotherapy? Chemotherapy alone, not a chosen modality, not a modality for cervical cancer. It's either radiotherapy or chemoradiation. If they had said chemo here and radiotherapy, answer would have been radiotherapy. Radiotherapy is the primary modality, but preferably it is given along with chemo. So chemoradiation is your answer. Chemoradiation is your answer. So please remember stage 2B and beyond. This is how I remember. What is stage 2B? The moment you see that the parametrium is involved, that is when stage 2B starts. The moment parametrium starts getting involved, it is stage 2B. Stage 2B and beyond, it is chemoradiation. Also remember bulky growths. They may be limited to the cervix or the upper vagina. They may be limited to the cervix or the upper vagina, but wherever you see size more than 4 centimeter, it becomes inoperable. It becomes inoperable. Keep that in mind. Okay, so let's have a look at the FIGO staging of cervical cancer, and I will highlight what are the key important things that you need to remember. Okay, like I said, stage, look at this. This is stage 1, limited to the cervix. Stage 1, limited to the cervix. I'll come to stage 1A, 1B. 1A is micro-invasive. It is not visible on the outside, but it has been diagnosed on a LEAP report or a conization report. Then 1A1, 1A2, depending upon the depth of invasion. This is the basement membrane and this is the stroma. So depth of invasion, less than 3 mm, 3 to 5 mm. Okay, so just remember stage 1A is micro-invasive. 1B is invasive, meaning visible growth. Okay, visible growth. Then 1B1, 1B2, 1B3, less than 2, more than or equal to 2 and less than 4 centimeter, more than 4 centimeter. So this is your bulky growth here. Remember, this is your bulky growth here. 1B3, visible lesion, invasive cancer, bulky growth. Circle it, highlight it, right? Now, stage 2. 2A is here. Upper 2/3 of the vagina. Then bulky, 2A2, size of the growth more than 4 centimeter. 2B is here towards the parametrium. That is how cervical cancer spreads, towards the parametrium. So 2B is here, parametrium, but not up to the lateral pelvic wall. Stage 3, you need to remember, I am highlighting it as a star mark. This can be a direct question. 3A is again now lower 1/3 of the vagina. 3B is here, parametrium up to the lateral pelvic wall. So in the previous question, if they had asked you what is the stage, most likely the stage would have been 3B, depending upon the what they have told you, right? So here, coming back. So 3B is lateral pelvic wall involvement now, parametrium up to lateral pelvic wall. And stage 3C, remember pelvic and or para-aortic lymph nodes are stage 3. Remember pelvic and or para-aortic lymph nodes are stage 3. So these are retroperitoneal lymph nodes are stage 3. Okay. Stage 4 is now bladder and rectum. And 4B is distant metastasis. Also write down, most common site for distant metastasis is the lungs. Most common site for distant metastasis is the lungs. Okay. And apart from, and which group of lymph nodes are involved? This also they ask you. Which group of lymph nodes are involved? This also they ask you. Now when they say pelvic group of lymph nodes, okay, then they're talking about internal iliac group of lymph nodes and, external iliac group of lymph nodes, obturator lymph nodes, right? So write down other one-liner important questions. Here we can make a side note that when they talk about the lymph nodes involved, Obturator lymph nodes, these are a part of internal iliac group of lymph nodes only. They are the most commonly involved, and these are the sentinel lymph nodes. I'll just write here. Sentinel lymph nodes are the paracervical, or also called as parametrial lymph nodes. These are the lymph nodes that are involved first. One lymph nodes you didn't find mention, inguinal lymph nodes. Inguinal lymph nodes are stage 4. Inguinal lymph nodes are almost never involved. Very, very extremely rare to see inguinal lymph node involvement in cervical cancer. Extremely rare, almost never involved. If at all, it will be stage 4. It will be far advanced. Okay. Now, please remember other important questions, that in this staging, upward spread is disregarded. Upward spread to uterus is disregarded in staging. Ovaries are hardly ever involved in cervical cancer. It doesn't go upward like that. It is disregarded as far as staging is concerned. Hydronephrosis, irrespective of size of growth on the cervix, will be taken as stage 3. Most common cause of death in cervical cancer, these 2 points are written together so that you remember that most common cause of death in a cervical cancer patient is obviously going to be an advanced cervical cancer patient. It's not bleeding, it's not hemorrhagic, because generally patients with bleeding will come sooner to the hospital. So keep that in mind. The most common cause of death in cervical cancer patient is, again, renal failure. Okay, and bullous edema of bladder, please remember, bullous edema of bladder is not stage 4. So to call a stage 4, if there is a suspicion that the patient is, let's say for example with cervical cancer, is also presenting with hematuria, let's say, then we have to find if the hematuria is because of the cancer having spread to the bladder, and then a cystoscopy will be done and a biopsy will be done. So bladder, wherever the cancer has spread, has to be biopsy proven. Similarly, if a patient with a diagnosis of cervical cancer, if she is complaining of rectal bleeding, then proctoscopy will have to be done like that. Okay, so the spread has to be biopsy proven. So staging, when you look at the cervical cancer staging, it is partly done based on physical examination, and nowadays all investigations are allowed. All investigations are allowed. Chest X-ray to look for lung metastasis, right? Or let's say a CT scan, PET CT scan to look for lymph node enlargement in the pelvis. So all of these investigations are allowed for better treatment planning. Now, let's look at the next question. And if you've been listening to me carefully, you will know the answer. A 35-year-old woman is diagnosed with squamous cell cancer of the cervix, stage 1B. Stage 1B is visible growth on the cervix, okay? And it is invasive, right? That's stage 1B. During radical hysterectomy, which structure is not removed? So, one thing that you need to make out from here, that yes, stage 1B, we are doing radical hysterectomy surgery. Okay, they are asking you which structure is not removed. If it's a radical hysterectomy, yes, along with the uterus and cervix where the growth is, adjacent tissues have to be removed, right? The parametrium is removed. In radical hysterectomy, the parametrium is removed. Okay, the extent of the parametrial removal or later dissection, that will depend upon the radicality of the hysterectomy, the different radical types, how radical you go, how extensive the dissection becomes. Primarily, remember, parametrium is removed, vaginal cuff is also removed. So, upper third of vagina is removed. Along with that, pelvic lymph nodes are also removed, right? And uterosacral ligament is also removed. Okay, so these structures are removed. But in a young woman, you can preserve the ovaries, you can preserve both the ovaries. That is one very important advantage of surgery, that ovaries can be preserved. Ovaries will not be able to preserve the ovaries. It will become very difficult if radiotherapy is used. Okay, so both ovaries are hardly ever involved in cervical cancer. So if it's a young woman undergoing radical hysterectomy surgery for cervical cancer, ovaries can be saved. Ovaries need not be removed. Right now, if you look at the stage-wise treatment of cervical cancer, let's just dig in a little bit deeper. For the FMG students, let me tell you, it's okay if you don't remember this in too much detail. Just for the FMG, however, for NEET, PG and INI-CET, they tend to go in depth, right? So with that perspective, please, like I told you, stage 2B and beyond, the bulky growths. Where were the bulky growths? 1B3 and 2A2. There were the bulky growths more than 4 centimeter in size. It's chemo radiation. Okay, no fertility preserving surgery. No fertility preserving surgery. It's chemo radiation. Chemo agent of choice, cisplatin. Other agent, 5-fluorouracil has also been used if cisplatin cannot be used. And the chemo acts as radiation sensitizer. Radiation sensitizer. Okay. Fine. Now, stage 1A1, no LVSI. LVSI is for lymphovascular space invasion. Here one can do extrafacial, that is type 1 hysterectomy. This is treatment, preferred treatment. And if the family is not complete, then conization. Okay. Stage 1A1 plus LVSI. Here, stage 1A1 plus LVSI and 1A2. Okay, these are still micro-invasive. These are still micro-invasive. Modified radical, that is type 2. This is also called as Verdheim's. FMG students, please know Verdheim's is a surgery for cervical cancer. This is a type of radical hysterectomy, modified radical hysterectomy, plus pelvic lymphadenectomy. Okay, 1B1, 1B2, 2A1. Okay, so invasive cancer basically invasive cancer, type 3. Type 3 radical hysterectomy plus pelvic lymphadenectomy. Okay, so this is basically invasive cancer. Alright, now have a look at this. Family complete. Family complete, that means family not complete. Family not complete. Fertility preserving surgery is an option only till 1B1. Only till this stage, fertility preserving is an option. So here, no fertility preserving surgery. Only till 1B1. Growth limited to cervix, size less than 2 centimeters. This is how I remember. I don't remember the entire staging. I recall the important pointers. I recall the important pointers wherever applicable. So, growth on the cervix, size less than 2 centimeter. That is 1B1. Only till that stage, what do? Radical trachelectomy is an option for those where family is not complete. FMG students, please at least know what trachelectomy means. Radical trachelectomy means that the cervix, upper 1 to 2 centimeter of the vagina, parametrium is removed, lymphadenectomy is done, and a permanent cervical cerclage is placed. Please remember, ovaries are not removed in younger women, and radiotherapy can be used in all stages. It's not like radiotherapy cannot be used. So, for example, if a patient is early stage but it is an unfit candidate for surgery for whatever reason, then radiotherapy can be used in all stages as well. Okay. So, these are the high-yielding pointers, must-know high-yielding pointers about cervical cancer. Let's talk about the next question. Let's move ahead with our revision. All of the following are risk factors for epithelial ovarian cancer except. So, these risk factors, they're generally defined for epithelial ovarian cancer. Nulliparity is a risk factor, yes. Early menarche, late menopause, yes. So, what happens with nulliparity, late menopause, early menarche is that it is said what we call as the theory of incessant ovulation, meaning there is no halt during the entire age of the woman, there is no halt or there is no stopping of ovulation anywhere, right? So, in periods of pregnancy or, lactation, breastfeeding, ovulation is suppressed, right? with nulliparity, there is no suppression of ovulation at any given point in time, right? So that's the logic, that that is what they say, theory of incessant ovulation for epithelial ovarian cancer. So nulliparity is a risk factor, yes. Early menarche, late menopause, yes, is a risk factor, again for that very same reason, long duration of reproductive lifespan. Increasing age is actually one of the most important risk factor, yes. And tamoxifen is not a risk factor for epithelial ovarian cancer. Tamoxifen is a risk factor for endometrial cancer. It is a selective estrogen receptor modulator with estrogen agonistic action on the endometrial lining, right? So they tend to ask you this question sometimes, that, you know, a woman is, let's say, having abnormal uterine bleeding or postmenopausal bleeding, and she is on, let's say, tamoxifen therapy for breast cancer. She's a breast cancer survivor and now she's having these symptoms. What could the potential cause be? So this is basically a risk factor. Tamoxifen therapy causes endometrial hyperplasia, risk factor for endometrial hyperplasia and cancer. Right? So this is not a risk factor for epithelial ovarian cancer. We've read the risk factors for cervical cancer in the previous slides, right? Cervical cancer risk factors have got all to do with acquiring and persistence of HPV infection, because that is the primary causative agent for cervical cancer. But now you'll realize and understand the difference when you look at the risk factors for epithelial ovarian cancer. So risk factor for epithelial ovarian cancer, think about it like this, theory of incessant ovulation. There is a mnemonic also, no child. So nulliparity, Caucasian, it is more common in Caucasian, right? And hereditary family history is also there, increasing age, late menopause, early menarche, delayed childbearing. Smoking is a risk factor for mucinous histology only, right? O was for ovulation induction drugs, okay? O was for ovulation induction drugs, but the recent studies have shown that the risk with ovulation induction drugs is very controversial, okay, possibly for the borderline histology, but it is controversial, so I have not included it in the risk of valid risk factors for epithelial ovarian cancer, okay. Now protective factors, very, very important to know. Multiparity, OC pills, they are protective for both endometrial cancer as well as ovarian cancer. Please remember these important pointers, very, very important to know. And also make a look at this side note here. Also look at this side note here. Early menarche, late menopause, nulliparity, obesity. Obesity again, a situation where in the peripheral fat cells, estrogen is formed by aromatization of androgens, right? So more of hyper estrogenic situation with obesity. These are all risk factors for endometrial cancer. So for endometrial cancer, the risk factor would be any situation which is causing hyperestrogenic situation, you know, or excess estrogen causing endometrial proliferation, right? So prolonged history of anovulatory cycles, is also a risk factor which can be associated with PCOS, which can be associated with the infertility also, right? Keep that in mind. Now corpus cancer triad, it is contains of what? Three things. Corpus meaning body of the uterus. So it is talking about endometrial cancer. Generally the women suffering from endometrial cancer tend to be obese, tend to be diabetic, and tend to be hypertensive. That's what the triad is about, right? But please remember, hypertension by itself per se is not a risk factor, right? So if they say that all are risk factors for endometrial cancer, except they say obesity, diabetic, tamoxifen, early menarche, late menopause and all this and that, and they mention hypertension as another standalone option, then hypertension by itself per se is not a risk factor. There's no causal link. However, yes, because these women tend to be obese, diabetic, older in age, hypertension, they generally suffer from hypertension, right? So keep that in mind. Also remember here that multiparity, OC pills and smoking. Now look at this here. Smoking is protective because smoking causes estrogen breakdown in the body. So these three are protective for endometrial cancer. So you will have to, understand. Please remember, compare and learn. Try to compare and remember. So smoking was a risk factor as far as ovarian cancer was concerned. Smoking is a risk factor for mucinous histology. Smoking was also a risk factor for cervical cancer. Smoking, we will see, is a risk factor for vulval cancer also. But for endometrial cancer, smoking tends to be protective. So keep this, again, important distinction in mind. Now let's have a look at the next question. A 60-year-old woman presents with long-standing complaint of, so look at her age, look at her non-specific GI symptoms, which tend to be the most common presentation. Most common presentation tends to be non-specific GI symptoms. Complain of dyspepsia, bloating, progressive abdominal distension. What is this abdominal distension? This abdominal distension could be the tumor itself, ovarian tumor itself, or it could be the ascites that is happening, right, because of that, or it could be the pelvic deposits, intraperitoneal deposits, it could be omentum deposits. That would all contribute to abdominal distension. See, imaging reveals ascites with omental caking and bilateral adnexal masses. So the adnexal masses are not too big. They're not too big. They're 6 centimeter each, adnexal masses, right? But the fact of the matter is that even though the adnexal masses are small, the cancer has spread already, causing ascites, omental deposits. And if you look at the characteristics of the masses, multiple septations and papillary excrescences. So papillary excrescences are basically solid areas and with obviously a papillary looking appearance. Multiple septations are there. Now, when you have a situation like this, where the age of the patient, the clinical examination findings, the ultrasound features suggestive of malignancy in a woman who we are suspecting ovarian cancer, yes, especially post-menopausal, older women, the next step that you do, again, you have to see multiple questions from the single question that I give you, right? So, in a woman who is post-menopausal, she is having adnexal masses, you need to send CA-125 levels before we decide on surgery or anything. Now see, CA-125 is not making the diagnosis of cancer per se. None of the tumor markers have got sensitivity, specificity. Tumor markers may at the most point towards a particular histology, may point towards the diagnosis of cancer, but tumor markers are never 100% making the diagnosis of cancer. So why the hell are we doing these tumor markers? We're doing these tumor markers, and which we should be doing is so that, see, we have a baseline tumor marker. So we have, let's say, a stronger suspicion of cancer, so that if tumor markers are elevated, one can, refer the patient to a gynae oncosurgeon. That is the utility of sending a tumor marker. The other utility is that, let's say somebody decided, no, I'll operate this patient, because ultimately whether it is cancer or no cancer, diagnosis will be made on histopath, final histopath. See, ovarian cancer, interesting thing to look at it, ovarian cancer, interesting thing to look at it is that with endometrial cancer, you have histopath diagnosis from endometrial sampling. With cervical cancer, growth, you have diagnosis. With vulval cancer, you have growth, you have diagnosis. Ovarian cancer, you don't have diagnosis like this. The very valid way of having a diagnosis of ovarian cancer, getting the histopath, is surgical removal of the mass and then, confirming whether it is cancer or not. That is the way we generally do things, right? And so CA-125 levels are done before opting for surgery, before doing a surgery. Why? So that we have a baseline tumor marker level, because after surgery, we will follow up the tumor markers. We will see that the tumor markers will decline, they will become absent, from circulation. And later on, long-term follow-up, if tumor markers rise again, we can think about the possibility that this is recurrence of cancer. These two are the valid indications for getting tumor markers done, but they should be done before subjecting to surgery. Clear? Remember this concept. So CA125 levels are elevated, okay, normal are less than 35 international units per liter, most likely diagnosis. Right. So, what is the most likely diagnosis? The answer is serous cyst adenocarcinoma. Why? Because this is the most common type of histology, responsible for 75% cases. This is epithelial ovarian. Why not mucinous? I'll tell you why not mucinous. Mucinous grows to large sizes. Okay, mucinous is the second most histology, mucinous goes to large sizes, and if they had to ask you about mucinous, they would have mentioned different tumor markers. Granulosa cell tumor also in this age group, sex cord stromal cell tumors is, granulosa cell tumor is a sex cord stromal cell tumor. Generally in the age group 35 to 45 years of age group. It can happen in juvenile young girls also, but age is making it an unlikely possibility. With granulosa cell tumor, it's a different profile. They would have mentioned different tumor markers. Endometrioid is uncommon, so this is generally not asked. So these are not your answers. So generally with ovarian cancer, the sort of questions they tend to ask is they will give you a clinical profile, they will mention something about the tumor marker or some key specific feature about the histology. So it becomes a path and a pathology and gynae integration sort of a question. So you do this, and in your path lectures also, in your path revisions also, this is very much covered. So I'll be quick about it. So you can see here image on the right showing the serous histology, okay, and I know that this is a serous histology because ultimately it is biopsy proven. Just by the look of it, I can only make the likely possibility. I can make the likely possibility because there are bilateral masses, there are solid cystic areas, papillary excrescences, right. So I can make the assumption that this is most likely serous histology. A tumor marker may guide me, but ultimately it has to be proven histopath, right. So serous histology, Samoma bodies are seen on histopath. I remember it as serious SAM. And very important potential question, please make a note, type 1 serous histology is low grade associated with mutations in KRAS and BRAF, and type 2 serous histology is high grade serous histology, high grade lesion and mutation in P53 gene. This is very important, please make a note of this as well. Okay, and then you have mucinous histology. Mucinous histology, if they have to ask questions on that, they would mention loculi filled with mucin. They often are huge, grow to large sizes, unilateral. They have a slightly better prognosis as compared to the serous histology. Why? Because they tend to be diagnosed early, because they grow to large sizes, often are unilateral, tend to be diagnosed early, so better prognosis. The tumor marker is CA19-9 and CEA, carcinoembryonic antigen, and it can be associated with pseudomyxoma peritoni. Okay, so these are other important questions. So they may tell you that when the abdomen was opened and cancer surgery was being performed, there was this, the peritoneal surfaces was covered with a thick gelatinous substance. If they give you this kind of a clue, it is talking about pseudomyxoma peritoni, and then the most likely histology is mucinous histology, right. So these are the sort of questions they are going to ask, right. Now, which is the histology which is associated with hobnail cells and high grade malignancy? Clear cell histology. Okay, transitional cell histology and solid tumors generally, they are mostly benign and unilateral. Walther cell nest on histopath, what is it? This is Brenner's tumor. Please remember that Brenner's is a type of epithelial, clear cell is type epithelial, mucinous histology is epithelial, serous histology is epithelial. These are all epithelial cell cancers. Okay. Now, borderline tumors are also there. They are tumors of low malignant potential. Important thing is that there is epithelial hyperplasia and atypia and destructive stromal invasion is absent. This question has been asked in NEET PG earlier, so that is why we are repeating it here. Okay, what does borderline histology mean? And again, this is covered in PATH, so we'll be quick about it. Now, other special features, look at this here, ovarian tumor, special feature, and the image here, histopath image here. So, what we are seeing here is a granulosa cell tumor. Okay, so the profile could be a reproductive age group woman with AUB, a postmenopausal woman with postmenopausal bleeding, or a young girl with precocious puberty, and they may tell you that she is also having excessive vaginal bleeding or something like that. That sort of a profile is there because this tumor secretes estrogen. But estrogen cannot be a tumor marker because it is otherwise anyways present in the in the female body, right? So the tumor marker is inhibin. Tumor marker is inhibin. On histopath, what is seen? Coffee bean nuclei. I remember it as granny calls for coffee. Coffee bean nuclei, and call is for Call-Exner bodies. Call-Exner bodies. Okay, so please remember this. So there are coffee bean nuclei, and these malignant cells are arranged like follicles in the ovaries, right? So those are called as Call-Exner bodies. It's rarely bilateral and it is associated with FOXLT gene mutation. This question has not been asked, but this seems like a potential question, a very specific mutation associated with granulosa cell tumor. Then, what is this ovarian cancer? Adnexal mass is in a reproductive age group woman, and she is having hirsutism and features of virilization. On histopath, Rinke's crystals are there. This is certainly Leydig cell tumor. Okay, fibroma is benign. Please remember that. Solid tumor. It is associated with Meeks syndrome. What is Meeks syndrome? Fibroma, a benign ovarian mass plus ascites plus pleural effusion. This is not malignant ascites, not malignant pleural effusion. This is reactive ascites, reactive pleural effusion. Once the benign tumor is removed, ascites and pleural effusion settle down. Okay, and then we have the Krukenberg's tumor. This is metastatic tumor to the ovary, most commonly from the stomach and then from the breast. On histopath, there are signet ring cells. There are signet ring cells filled with mucin. So this is Krukenberg's tumor. Okay, they are usually bilateral, not always. They are usually bilateral, not always. Okay, the capsule of the tumor also tends to be intact, but most importantly, histopath characteristic feature of signet ring cells. Let's look at the next question. An 18-year-old girl presents with abdominopelvic lump. On ultrasound evaluation, it is found to be a solid cystic ovarian mass measuring 10 centimeter, which is a big mass. Raised blood flow inside the mass. So in the previous question, what did we see? Solid areas, solid cystic areas, papillary excrescences. In the previous question, there were obvious evidence of metastasis, ascites. Maybe pelvic deposits are there. What is this raised blood flow inside the tumor? This is vascularity. Can you see? This is the ovarian mass. This is the ovarian mass. If you look at this image, these are the multiple septations. This is the solid cystic area. This is the solid cystic area, and this is the vascularity. Very important characteristic of tumor or cancer. Not tumor, can be benign also. Very important characteristic of malignancy is neovascularization. So raised blood flow inside the mass on Doppler. This is all raising the suspicion of malignancy, particularly the young age of the girl is also raising the possibility of a malignancy. What is the most appropriate next step? What did I tell you before jumping to surgery? Right, it is very important to send the tumor markers. Now see, here the valid tumor markers, okay, baseline CA125, it's not like epithelial ovarian malignancies can never happen in young women. Obviously, in a young girl, in young girls like 10 to 30 years of age, germ cell cancers are most likely. Okay, peak age of germ cell cancers is 10 to 30 years age. Okay, germ cell cancers, they often tend to be unilateral. Germ cell cancers, how are they different from epithelial ovarian cancers? Is that they grow to large sizes. one question will make you remember all of these extra pointers. Germ cell cancers often tend to grow to large sizes. There's a lot of vascularity inside the germ cell cancer. There can be bleeding inside the germ cell cancer substance, right? Because of that bleeding, because of that and huge ovarian size, the capsule of the ovary can get stretched. So you have to understand that with the epithelial ovarian cancers, they tend to have late presentation, long-standing, non-specific GI symptoms, and finally presenting in advanced stages. How are germ cell cancers different? They're different. Age group different. Secondly, they tend to grow to large sizes and they can be painful. Right? Abdominopelvic lump, huge sizes, can be associated with pain. And that is why generally tend to present earlier. Often when they present, they are often unilateral by the time they are presenting. So early diagnosis, better prognosis as compared to epithelial ovarian cancers, right? So remember these important pointers, right? Now, if I'm suspecting a germ cell cancer based on the clinical profile, the markers that I have to be sent are different. So, yes, of course, a baseline CA125, but I will not go for CEA. This is mucinous histology, right? This is unlikely. So, the best answer is B, CA125, AFP, HCG, LDH. Okay. Now, I'll give you the important pointers for the tumor markers in the next slide, but let's just talk about no diagnostic laparoscopy right now, right? The suspicion is cancer, ideally send the tumor markers, ideally should be opened up or planned for a surgical procedure by gynae-onco surgeon. So this is out. Now, the fourth point, ultrasound guided FNAC. Ultrasound guided FNAC is not the routine thing to do for the diagnosis of ovarian cancer. Please remember, just make a side note somewhere, and this is how you are going to remember, okay? The most common route of spread of ovarian cancer, this is distinct, this is unique, that's why it is important. The way the ovarian cancer spreads is by tumor exfoliation along peritoneal surfaces. Okay, so tumor cells exfoliate, fall into the peritoneal cavity along peritoneal surfaces, it spreads, and that is why it so rapidly spreads to the pelvic and the intraperitoneal structures, and it so rapidly spreads to the lymph nodes also, right? So that's why generally they tend to be more aggressive if you compare them to other gynae cancers like endometrial or ovarian. So this is the most common route of spread. Now, if I'm going to do an ultrasound guided FNAC, so the ovarian capsule is intact, right? But what am I doing? I'm doing an ultrasound guided FNAC, making a needle tract into a mass that is possibly malignant and harboring malignant cells. Now, when I do an ultrasound guided FNAC, I create a needle tract, I break of course, it's just a pinch, of course, it's just a pinprick. But still, I break the continuity of the tumor capsule and the possibility of tumor exfoliation increases. Possibility increases. No, possibility increases. So why go for an ultrasound guided FNAC? Right? So, because ultimately, yes, one has to open and remove the mass and make a diagnosis. Right? And obviously with intraoperative findings as well. So, all tumor workup, tumor markers, CT scans, all that metastatic workup is done and a surgery is planned. So, ultrasound guided FNAC, not routine. The only place where ultrasound guided FNAC could potentially have a role is when anyways the patient is in advanced cancer. The entire clinical profile, examination, finding, CT scan, I'm very certain that this is advanced cancer and maybe she is not operable. Okay, she's not operable. We are not deciding to do surgery because for medical reasons or surgical reasons, she is inoperable and we decide, okay, let's go for chemotherapy first. And before giving chemotherapy, we want to have a histopath diagnosis of cancer. That is the dictum. Okay. So then maybe it's already advanced. Then maybe ultrasound guided FNAC to have a biopsy proven report so that one can initiate chemotherapy. That is one situation where it will have a role. right? Routinely, no. So this is not the answer. So I've given you extra bits, extra clinical tidbits also from this question. So we've discussed this a lot. Let's have a look at some important characteristics of germ cell cancer. So the easy questions from ovarian cancers would be that they would give you a clinical profile, some distinctive feature about the tumor. Maybe they could say that the tumor was cut open on frozen section. This was found, like for example, there's a tumor in a young girl. Okay, and she has, an ovarian cancer. They give you some information about the tumor marker that is raised, and they may tell you that during surgery, when the frozen section was sent or when the histopath was done, it's showing lymphocytic infiltration, right? So these keywords are something that you need to look for in the question. That is why they are highlighted, okay? So dysgerminoma is the most common type of germ cell cancer. Dysgerminoma is also the most common ovarian cancer identified during pregnancy, okay? And what is the tumor marker? LDH is the main tumor marker. Placental alkaline phosphatase is also raised. HCG can be raised. Never AFP. Alpha fetoprotein comes from embryonal structures. It will never be raised in dysgerminoma, but the primary tumor marker is LDH. Remember this. Can be bilateral in 10 to 15% cases. Lymphatic spread is very common with this dysgerminoma. It is also the most common type of tumor to arise in dysgenetic gonads. Dysgerminoma is the counterpart of seminoma of the testes. So if you recall, seminoma is very radiosensitive. Similarly, dysgerminoma is also very radiosensitive. That's true. But radiotherapy is not the primary modality of therapy in treating ovarian cancer because that sacrifices the ovary and reproductive potential of these young women or young girls, right? Immature teratoma, not much to know. Immature teratoma is the second most common type of germ cell cancer, and it's severe. It's graded according to the immature neural elements. Its grade of severity or grade of malignancy is graded according to immature neural elements. Endodermal sinus tumor are also called as yolk sac carcinomas. Their tumor marker is AFP. They are very aggressive but uncommon. Always unilateral. On histopath, what do we see? We see these cancer cells surrounding, a tuft of capillaries. So these are called as Schiller-Duval bodies. Schiller-Duval bodies. Again, you read this in pathology, so I'm not going to go too much detail into this, but these are the important pointers you need to keep in mind. Apart from these, there is embryonal cell cancer. Okay, and there is choriocarcinoma. Now, this choriocarcinoma is not the same choriocarcinoma as choriocarcinoma of uterus, but it is in the ovary. It is highly aggressive malignancy and it also secretes HCG. And just to complete the list, embryonal cell secretes AFP, also secretes HCG. Okay, now let's recall the management of ovarian cancer. So, what have we discussed so far? A clinical profile, a presentation, an ultrasound to begin with, ultrasound characteristics making us highly suspicious of malignancy. We've done the tumor markers, we've got the raised tumor markers, and we're deciding on the treatment modality, we're deciding on the management after doing a full metastatic workup. Okay, so full metastatic workup will, what we do, the radiologically will depend upon what is our clinical suspicion, right? So if you want to see the intrapelvic deposits, we want to see the enlarged lymph nodes, we can do the CT scan, right? If we are suspicious that there is there's maybe a pleural effusion, maybe a malignant pleural effusion, a woman with ovarian cancer diagnosis is becoming breathless, and you're suspecting that there may be malignant pleural effusion, we do go for a chest x-ray, right, isn't it? And if we have further more suspicion to see lung metastasis, we may go for a CT scan. So investigations, radiological investigations are done as required. Please remember, if it is malignant pleural effusion, it has to be tabbed and it has to be proven that it is carrying malignant cells. Keep that in also mind, okay? Like anywhere, if you have to say that the malignant cells are involving this particular site, it has to be proven by cytology or biopsy or whatever. Okay. So we're doing the workup, we're doing the metastatic workup, and finally we're deciding on the management. So management is staging. It's primarily surgical. Ovarian cancer management is primarily surgical. Staging is surgical staging always. Staging finally is surgical staging. We have a radiological perception, we have a radiological suspicion, of course, but ultimately it is surgical staging and has to be histopath proven. Surgical staging includes obviously opening the abdomen, right? It is usually an abdominal procedure like cut open. Ascitic fluid peritoneal cytology is taken. We remove the tumor deposits and we take the representative biopsies. We have to inspect the entire pelvis and the peritoneal cavity, and we have to do TAH plus BSO. Uterus you have to remove. Okay, along with both the, this is the standard, I'm talking about standard procedure, right? Plus pelvic and para-aortic lymphadenectomy, plus infracolic omentectomy, omentum is also removed, plus appendectomy if it is a mucinous histology. So appendectomy only if it is a mucinous histology. If it is an advanced stage already, then it no longer becomes a staging, surgical staging procedure, but it becomes debulking surgery. Debulking surgery means cytoreductive surgery. Remove as much of tumor tissue as possible and post-operatively follow it with chemotherapy. So surgical staging meaning that, apparently stage 1 and 2. Stage 1 and 2. Apparently meaning that on initial examination, initial cancer workup, it seems like it is stage 1 and 2. Right? So how will you remember what is stage 1? Stage 1 of any cancer is that it is limited to whichever organ it was arising from. So stage 1 is limited to the ovaries. Stage 2, where will it go? Where will it go from the ovaries? It will go from the ovaries to the uterus, to the tubes, or it is still limited to the pelvis. It is still limited to pelvic intraperitoneal structures. That is how you should remember. So for this, yes, surgical staging is good enough. So ovaries, limited to ovaries, it seems it is limited to ovaries, or stage 2, it seems okay, it has gone beyond the ovaries, involved maybe the fallopian tubes, the uterus, but it is still limited to the pelvic intraperitoneal structures. This is how you're going to remember, right? Anything beyond that is higher stage. Anything beyond that is higher stage. Keep that in mind. Okay, so for that. Now, advanced stage, like I told you, that we go for debulking surgery, which is cytoreductive surgery. Post-op chemotherapy has to be given. Optimal debulking, we say, when less than 1 centimeter residual tumor is left behind. Okay, fertility preserving option. This is the standard therapy I told you, which involved along with all of this TH, BSO. Fertility preserving option. What is fertility preserving option? Meaning we do surgical staging plus unilateral salpingo-oophorectomy. This is an acceptable option for germ cell cancers, borderline tumors, stage 1A epithelial ovarian and granulosa cell tumor in young girls, where fertility preserving option is required for those who have not completed their families, who are younger, for them. It is an option. Beyond this, apart from these 4 situations, fertility preserving option is not going to be there. Also remember neoadjuvant chemotherapy. What is neoadjuvant chemotherapy? Is not the standard therapy. What was I describing to you? A situation, I just in the previous slide described to you a situation where a patient, let's say, was not operable, right? So neoadjuvant chemotherapy meaning give chemotherapy first. That will shrink the tumor, maybe make it more operable, and then at a later point in time, a cytoreductive or a debulking surgery can be done. So neoadjuvant followed by interval debulking. It is not the standard therapy. Okay, but it could be an option for high-risk surgical candidates or those with low likelihood of optimal debulking in the primary surgery, right? So this is the standard of care. Standard of care. Keep this in mind as well. Now moving on, other important pointers, like I told you, I was describing to you staging. Okay, so stage 1, I've already told you, limited to ovaries, 1A, 1 ovary, B, both ovaries, right? Now, as and when the capsule rupture or there is malignant ascites, this is important to remember. Like when we opened up for surgery, we found that the capsule of the tumor is already ruptured, capsule rupture, okay? Or accidentally, while removing the tumor, we ruptured the capsule in the pelvis, and or the ascitic fluid or the peritoneal cytology we had sent came out positive for malignant cells. Then this is stage 1C. Stage 2, I told you, uterus, tubes, pelvic, intraperitoneal structures. Remember stage 3. Lymph nodes, pelvic, para-aortic, retroperitoneal lymph nodes. They are stage 3. In cervical cancer, in endometrial cancer, in ovarian cancer. So stage 3 is retroperitoneal lymph nodes, remember this. Also stage 3 is intra-abdominal deposits, liver and spleen capsule. Stage 4 is, remember this, malignant pleural effusion. Very important for MCQs, inguinal lymph nodes are stage 4 with ovarian cancer. Liver and spleen parenchyma, distant mets, obviously they are stage 4. Along with that, liver and spleen parenchyma. But remember the points that I have highlighted for the staging. Also remember, what is the chemotherapy for epithelial ovarian cancers? Direct question they ask you. The drug of choice is combination of carboplatin plus paclitaxel. Okay, if carboplatin is not possible to give, maybe because of the toxicity profile for the patient, then the other alternative is cisplatin. So it's either of the platins plus paclitaxel, preferably carboplatin. Post-op chemotherapy in cases of epithelial is given to all except stage 1A or 1B, grade 1 or 2. Only in this situation, it can be avoided. Okay, this is more for NEET PG, INI-CET level. If clear cell histology is there, we always give post-op chemotherapy. Remember this as well. Now, chemotherapy for germ cell cancers, they ask you. The standard regime, there are various regimes, but the standard regime is BEP regime. BEP is bleomycin, etoposide, and P is for platin. P is for platin. Please remember. Okay. Platins are P and taxanes are T. Right. So don't remember P as paclitaxel. It's bleomycin, etoposide, and cisplatin. It is given to all except stage 1A dysgerminomas and immature teratoma stage 1, grade 1. This is extra again for NEET PG and INI-CET level. But till FMG level, you should know at least which chemotherapy regimens are given for which cancers, right? Similarly, for sex-cord stromal cell tumors also, the standard regime is BEP regime only for sex-cord stromal cell tumors as well. Now, next question. So we finished basic rapid revision recall of ovarian cancer also, the must-know key important pointers. Let's move on. There's a 60-year-old woman who presents with postmenopausal bleeding. On per speculum, cervix is atrophic looking. Histopath from endometrial fragments show atrophic endometrium. So yes, atrophic, it explains 60-year-old atrophic endometritis it's the most common uterine cause of abnormal uterine, of postmenopausal bleeding. Worldwide, it is the most common cause of postmenopausal bleeding, but in Indian women, yes, postmenopausal bleeding in Indian women, most common, it is cervical cancer, but they're not mentioning that there is any growth on the cervix. For past 3 months, bleeding episodes have become more frequent. So basically, this is persistent. Now, with this age, even if it is an atrophic endometrium on endometrial sampling, Even if on clinical examination, uterus is normal size, no problem, nothing, right? But the possibility of cancer has to be excluded. So she's having persistent symptoms. So now what needs to be done next? What do you think? Before, I'm telling you, the suspicion is that of cancer. So one cannot go for a cancer surgery without making a diagnosis of cancer. Without ruling out cancer, you cannot decide whether it is a simple hysterectomy you will do, which kind of hysterectomy we will do. The cancer diagnosis will be mixed. That is what happens when patients are inappropriately investigated and treated. Somebody will do a hysterectomy straight away in this patient, subject her to surgery. Hysterectomy report will show cancer, and then it is incomplete surgery. Now patient has to go for a repeat surgery or the mental trauma of a surprise diagnosis and then a resurgery, or, this is incomplete treatment, incomplete workup. So this should not be done. When the suspicion is that of cancer, when the possibility is that of cancer, it should be eliminated first before planning for what type of surgery. So it's not hysterectomy. CA-125 levels could be elevated in endometrial cancer, but it's not a marker. Please eliminate it. Right, so we don't have this CA-125 level here. Now, it's MRI pelvis or hysteroscopic examination, or MRI radiological investigation. What will it tell you? What will it tell you? See, they have already done a histopath. Most likely, they've done an ultrasound also, which is showing nothing but an atrophic endometrium. They've not given in this question, but maybe most likely by this time now, an ultrasound has also been done. Okay. So MRI pelvis, the utility of MRI pelvis is when we have a diagnosis of cancer for metastatic workup. MRI is very good in showing soft tissue delineation. So a cancer that is arising, let's say here in the endometrium, every word, just mark my word, all extra pointers worth remembering, and they become worth remembering because they become relevant somewhere or the other to me clinically. Right. So look at this, an endometrial cancers arising from the endometrial lining, it may grow to whatever levels. I mean, it may cause a polypoidal, fungating, ulcerative, whatever sort of growth inside the cavity. What matters is how deeply it is infiltrating into the myometrium. Most commonly spreads by direct extension. So first it goes deeper into the myometrium, it could go into the cervix, it could go into the fallopian tubes and the nearby ovaries. I mean, that's how it is going to spread most of the times. MRI helps there. Okay, to see myometrial penetration, to see if there's cervical stromal involvement and all that. But first we have to make the diagnosis of cancer. Right. So what we had done so far was an endometrial sampling, which is most often done in the OPD basis. So it must have been a blind procedure. So maybe there are some nooks and corners here in the endometrial cavity which have been missed. So the better way to go for a hysteroscopic examination, make sure that the entire endometrial cavity and entire endocervical canal in its entirety is explored and evaluated, and any abnormal area is biopsied and sampled. So we don't miss out on cancer. Hysteroscopic examination is the answer. Yes, of course, it will come with biopsy. Of course, it will come with biopsy. So that is your answer, and not MRI pelvis. Right? So MRI pelvis, I told you what is the utility. Similarly, when you have a diagnosis of endometrial cancer, CT scan will also give valuable information as to whether the lymph nodes are enlarged or not. So again, once the diagnosis is there, then there has to be a full metastatic workup, and then there has to be a treatment planning. Isn't it? Next question. A 62-year-old, lean and thin. Look at the age, but she's lean and thin. Generally, ovarian cancer patient tends to be obese. Who presented with persistent postmenopausal bleeding, underwent endometrial biopsy. She never had menstrual complaints in the past. So basically, no pre-malignant lesions were there. Otherwise, if pre-malignant lesions like endometrial hyperplasias would have been there, then generally they tend to have some history of abnormal bleeding in the perimenopausal age group also. Pelvic exam, normal. She underwent endometrial biopsy and has been diagnosed with endometrial cancer. On further workup, it is found that the cancer is confined to the uterus. Stage 1, to the uterus, stage 1. But she has been told that the prognosis is poor. Oh, what kind of a cancer could it be? What kind of a histology could it be that even though it is confined to the uterus, it is limited to the uterus, it is such bad that it is saying, the doctor is saying that the prognosis is poor. So what is the most likely histology? Endometrioid is the most common histology. It is good histology, fortunately. Mucinous is again a favorable histology. Mucinous carcinoma, mucinous adenocarcinoma can be there in the endometrium. It falls with the good histology, with the endometrioid type histology only. Leiomyosarcoma is again a cancer from the uterine myometrium, not endometrium. It's a very rare kind of a uterine malignancy. It's not endometrial cancer. So leiomyosarcoma, although it has got, it does not have a very good prognosis, but leiomyosarcoma is not diagnosed on, it's not, they're mentioning endometrial cancer. Leiomyosarcoma is not endometrial cancer. It's sarcoma arising from the uterine myometrium. Answer is uterine papillary serous carcinoma, type 2 histology. So as far as undergraduate level is concerned, instead of talking about the high-end questions of, cancer, they don't ask you too much. Undergraduate students, they don't ask you too much about the in-depth of the cancer surgeries, that you have a basic awareness of what cancer surgeries are. But they're more interested in asking you about whether you know how the diagnosis of cancer is made, what is the, what should be done, what should not be done as a part of the initial workup. Like tumor markers should be done, how should be the diagnosis be made, unnecessary, without complete workup, surgery should not be done. So these are the sort of things they expect you to know. Right now, nowhere else did we talk about histology contributing so much to prognosis, but in endometrial cancer. So this is a very key aspect, and that is why histology of endometrial cancer is most often asked from this perspective, from the perspective of prognosis. So what are the important pointers that you will remember? Now, the most common histology, 80% of cases is endometrioid adenocarcinoma. Okay, endometrioid. It has good prognosis. Remember this. Anything will have good prognosis if it gets presented early with an early diagnosis. It will have an early diagnosis if it gets presented, let's say, with some or the other pre-malignant lesion. So, she will have those symptoms and she will come into the OPD sooner. That's why it will be picked up early. That's how you remember it. So, the classical patient would be obese, pre and perimenopausal, estrogen responsive histology. It is seen with associated with atypical endometrial hyperplasia. Okay, and very important MCQ, most commonly associated with P10 mutation and good prognosis. KRAS mutation, if there is, it is particularly associated with unfavorable prognosis, slightly unfavorable prognosis, right? But please remember here, most commonly P10 mutation, and it is associated with good prognosis in endometrioid. Okay. Now, type 2 histology, serous histology, that is what we were saying, this uterine papillary serous carcinoma, this serous histology, clear cell histology, these two are the major counterparts. Okay, the interesting thing about these two, where else did I tell you these names? Serous. We talked about this in ovarian. Very interesting thing about type 2 histology is, I told you how this endometrial cancer usually spreads by direct extension. This type 2 histology tends to spread like ovarian cancer, like with tumor exfoliation. That's why it spreads rapidly, it's aggressive, it progresses to advanced stage quickly, it has poorer prognosis. That's an interesting thing to note, right? So, serous, remember this, right? So, poor prognosis tend to be seen in older, post-menopausal, lean and thin women. It is a type of estrogen unresponsive histology, so you generally don't find the pre-malignant lesions, right? and it arises in the background of atrophic endometrium. Very importantly, it is most commonly associated with P53 mutation, poor prognosis. Also associated with HER2 new mutation and P16 mutations. These are mostly done in path lectures, but let me summarize them here for completion's sake. But yes, these two mutations are associated with the type 2 histology with poorer prognosis, right? This is in detail, this is in depth. Basic remember, non-aggressive histology and aggressive histology. Non-aggressive histology is endometrioid grade 1 and 2. Aggressive histology is any non-endometrioid histology, and grade 3 endometrioid would also come in aggressive histology. Okay, grade means the solid areas, right? So more the solid areas in the histology, more is the grade. So aggressive histology, non-endometrioid histology, grade 3 endometrioid would also come, right? So broadly remember these two. What is aggressive histology? What is a non-aggressive histology? This much you need to remember. And then there is a list of poor prognostic factor. This is important for NEET PG and this is important for INI-CET particularly. And basically any non-endometrioid histology, grade 3 endometrioid, because aggressive histology will make a prognosis poor. So we've just elaborated it here. So histology tells us or gives us an idea about the prognosis. Apart from that, depth of myometrial invasion, cervical stromal involvement, okay, uterine serosa breached, adnexa involvement, lymph node involvement. This is not a separate list to mug up. The important thing is that you understand that as the stage increases, overall stage tells us about the prognosis of the patient. So as the stage of the cancer increases, right, histology is important in endometrial cancer. As the depth of myometrial penetration increases, right, if the cervical stromal involvement is there, it is going to increase the stage. If the uterus serosa is breached, it is going to increase the stage. If the adnexa are also involved, it is going to increase the stage. If the lymph nodes are involved, it will increase the stage. So basically, whatever is incorporated in the staging is actually giving us an idea about the prognostic factors. So this is important to note. Now they ask you the question that all are poor prognostic factors except. So please remember here that non-aggressive histology, endometrioid histology, grade 1 and 2, this would be a good prognostic factor. Another important thing I'm telling you, ER and PR positivity, estrogen receptor and progesterone receptor positivity in the tumor tissue is carrying good prognosis. At least if you can't mug up the list of poor prognostic factors, which I have told you is actually not a list to mug up, at least remember this is giving good prognosis. Okay. Now moving on, management of endometrial cancer. If it's clinically confined to the uterus, again surgical staging. Surgical staging standard treatment includes extrafacial total hysterectomy plus bilateral salpingo-oophorectomy plus para-aortic and pelvic plus pelvic and para-aortic lymphadenectomy. This is the standard of care. Of course, there will be situations where pelvic lymph node dissection could be avoided potentially, but not in all cases. Para-aortic lymphadenectomy, one may choose to do from a case-to-case basis. But undergraduate students, at least remember that this much needs to be done. This is the standard of care. But yes, there will be certain situations where pelvic lymph node dissection could be avoided potentially. If aggressive histology is there, then we also add infracolic omentectomy. If cervical involvement is there, stage 2, radical hysterectomy should be done. How radical it is done, it will depend. We have to achieve tumor-free margins during the surgery, and that will decide the radicality of the hysterectomy. If it's advanced stage, we go for debulking. plus post-operative chemoradiation. Now, what should you remember about the staging? You should remember stage 3. You should remember stage 3. What did I tell you? That endometrial cancer begins here from the endometrium, spreads deeper. Okay. So stage 1 is confined to the uterus. Stage 2 is it extends to the cervical stromal involvement. Remember this ways. Stage 3, it goes below, above and to the sides. Right. So see here, breach of uterine serosa or adnexa. Breach of uterine serosa or adnexa, 3A. Here, to the uterine serosa or adnexa, 3A. Okay. Here, 3B, to parametrium or to the vagina. Okay. And pelvic or para-aortic lymph nodes is stage 3C. 3A, 3B and 3C. Lymph nodes, 3C. At least remember this much. This is important. Pelvic and para-aortic lymph nodes, vagina or parametrium, breach of uterine serosa, pelvic peritoneum, all of this is stage 3. Stage 4, bladder or bowel, distant metastasis, inguinal lymph nodes, stage 4. Inguinal lymph nodes were stage 4 for ovarian also. Fine. Now, stage 1. Now, stage 1 has, see, when the FIGO update of the endometrial cancer came, stage 3 and stage 4 has remained the same. What they have changed is stage 1. What I want you to remember is stage 1 is confined to the uterine corpus. At least remember this much, because this staging has become very complicated now. Please remember 1A, 1B, non-aggressive histology. This you anyways used to remember earlier. It is confined to endometrium or less than 50% of myometrium and involving more than or equal to 50% of the myometrium. So it depends upon the depth of myometrial penetration, whether it will be stage 1A or 1B, but it has to be non-aggressive histology. This is new. This is the new thing that they have added. They have added a layer into the staging based on histology. Earlier it was only 1A, 1B. Histology was not counted. Now they are saying non-aggressive histology, then 1A, 1B, according to depth of myometrial penetration. And they are saying 1C, aggressive histology. It doesn't matter if it is confined to the endometrium, it is stage 1C. Right? The moment myometrial involvement happens with aggressive histology, it is stage 2. And that is why I say that it becomes complicated. So for now, what I need you to remember, is that histology is incorporated in the new staging. Lymphovascular space invasion is incorporated into the new staging. The grade of the lesion is incorporated into the new staging. These 3 things you note. It's okay if you don't remember the extensive staging. But please remember stage 2 is cervical stromal involvement. Remember this. Remember this. Stage 2 is cervical stromal involvement. So as long as it is confined to the uterus, it is stage 1. Okay. Please remember this. Stage 2, they have added other stage 2 also. Right, substantial LVSI, myometrial involvement with aggressive histology. So histology is, increasing the stage. But for now, remember stage cervical stromal involvement, if you find it is stage 2. And stage 3 remains the same. Stage 4 remains the same. And most of the times the questions are on stage 3 and 4. When direct stage related questions are asked. So I won't really spend too much of my head and time in trying to mug up stage 1 and 2 in too much depth and detail, but I would definitely try to understand and note that histology, LVSI, grade of the lesion, they are incorporated in staging now. And the new thing in endometrial cancer is molecular analysis of the tumor. It is mandatory that it is being done in all tumor tissues, right? So pole mutations are associated with good prognosis. microsatellite instability high or mismatch repair deficient mutations they are, and no specific molecular profile. They have intermediate prognosis, and P53 abnormal mutations in the tumor is associated with poor prognosis, and all histological types of endometrial tumors are subjected to molecular analysis nowadays. Okay. And that's why in ideal circumstances, endometrial cancer should be operated in gynae onco centers, so that all of these facilities are possible. Now, moving on, let's highlight the important pointers regarding vulval cancer. So, we'll be quick about this. Vulval cancer. See, the peak age of vulval cancer presentation is 65 to 75 years of age, right? And the most common presentation, there's a long-standing history of which pruritus, itching, because of the pre-malignant lesion that tends to be associated with vulval cancer, and that is lichen sclerosis. So you can remember it like that. Now, it doesn't matter that, and it doesn't mean that there cannot be other presentation. Obviously, with other presentation would be a grossly visible lesion on the vulva, right? A fungating growth or an ulcerative growth on the vulva, like it bleeds also. So that obviously will be there with cancer. But most common presentation is generally pruritus, right? Now, most common site is labia majora and then labia minora, right? If growth is seen, obviously, this diagnosis is made by punch biopsy. There's a specially designed Keyes punch biopsy forceps used to take biopsy sample from the region of the vulva, because sufficient depth of tissue has to be there. Now, if I'm saying sufficient depth of tissue has to be there, I'm talking about vulva, I'm talking about the stratified squamous epithelium of the vulva, that's the skin, right? And then it will have a basement membrane. So, I need the subepithelial layer also, na? I can't, if I want to diagnose cancer, right, just like in cervical cancer, right, there's epithelial, stratified squamous epithelial layer, and then the cancer cells will penetrate through the basement membrane into the stroma. So, I have to ensure that I take a deeper biopsy chunk, right? So, keep that in mind. If no gross lesion is there, dystrophic changes are there, unhealthy looking vulva, right? Sometimes there may be hypopigmented or deeply pigmented areas also. Melanoma also arises in the vulva, right? So, there can be dystrophic changes, there can be hypopigmented, deeply pigmented areas also. If there is no gross lesion, then vulvoscopy, just like colposcopy, vulvoscopy has to be done. Vulvoscopy with acetic acid, 5% acetic acid is also fine, but generally vulvoscopy with toluidine blue is what is done. But yeah, 5% acetic acid is also fine. Now, the most common route of spread is direct and then lymphatic. Okay, lymphatic spread to inguinofemoral group of lymph nodes, right? This is one cancer where there is proven role of sentinel lymph node sampling. Proven role of sentinel lymph node mapping and sentinel lymph node sampling. However, yes, please remember that in other gynae cancers also it is being attempted, the sentinel lymph node mapping, but for undergraduate level, for now, remember, it has a very well defined definitive role in vulval cancer. So, keep this in mind. Now, the most common histological type, again, squamous cell cancer. Most commonly, we have the keratinizing type of histology, keratinizing type. So, remember, most common age group, older age group. Keratinizing type in older age group. So, older women. Associated with the most common presentation, pruritus. Why did I tell you pruritus was there? Because of a long-standing history of some chronic lesion which is leading to itching also, right? So, that history, this is how you should remember. So, associated with lichen sclerosis, this is one important risk factor, and or differentiated vulval intraepithelial neoplasia, differentiated VIN. Whether a VIN, vulval intraepithelial neoplasia, is differentiated or high-grade VIN, this is more of a pathology question, but again, it depends upon the histopath findings, right? Then we have the warty or basaloid type. Warty or basaloid type is seen in younger women. Warts are seen in which women? Warts are HPV related. Younger women. Associated with HPV, HPV 16 most commonly, then 33, then 18. And with HPV, remember high-grade vulval intraepithelial neoplasia. And remember the risk factors are HPV is obviously causative, but other risk factors are HIV and smoking. So this is sort of similar to cervical cancer, HPV related. So what your basaloid type of histology is HPV related. Remember this. Now, very important, it is not related to parity, gravidity and lichen simplex. Paget's disease of vulva, direct MCQ pointer associated with adenocarcinoma of the vulva. Bartholin's gland cancer could be squamous, could be adenocarcinoma or transitional cell cancer. All of these three kinds of histological cancers could arise from the Bartholin's gland. Now, management of vulval cancer. Stage 1 is confined to the vulva. Cancer limited to the vulva. So, I'll remember it as like that. Stage 2 is, it has gone beyond the vulva. But I will say it is still resectable. Surgically operable. This is how you're going to remember the staging. Okay. So, stage 1A confined to the vulva, but size less than or equal to 2 centimeter and depth of stromal invasion less than or equal to 1 mm. This is the only earliest possible stage where wide local excision of the tumor is, or of the cancer is good enough, should be treatment enough, right? And that is the thing. Now, stage 1B. Now, it is more than 2 centimeter and or depth of stromal invasion more than 1 mm. Okay, or stage 2. What is stage 2? So, this is stage 1, this is stage 1. What is stage 2? Growth could be of any size, but what did I tell you? Direct extension into the lower 1/3 of the urethra, vagina or anus. So, it is still resectable. Here also it is still resectable. Here also stage 2, but still resectable. Okay, then we do something for the primary tumor. Primary tumor is the growth on the vulva. We go for a radical wide local excision. Okay, now it is still a radical wide local excision. So, tumor-free margins have to be achieved. Okay, and at least 2 centimeter tumor-free margins have to be achieved while excising. One may end up doing a unilateral or a bilateral vulvectomy depending upon how big the growth is on the vulva. So, one may end up doing a bilateral or a unilateral vulvectomy, but it remains the purpose is to achieve a radical wide local excision. One may end up doing a unilateral or a bilateral vulvectomy. Now, management of lymph nodes has to be also done in this situation. In this situation, that is why they are all marked under green box. Management of lymph nodes, right? So, management of lymph nodes has to be done if it is 1B, or if it is obviously frankly a stage 2 cancer, but also if you have, suspicious or enlarged lymph nodes, then you can't leave them now. If the lymph nodes are suspicious, enlarged, because clinically you can see the lymph nodes, inguinofemoral lymph nodes on clinical examination. If they seem suspicious, if they look enlarged, then also you will do. Then also you have to manage them. You can't keep them. You have to remove them. Now, please, if it is a small lateral lesion meaning less than 4 centimeters in size and more than or equal to 2 centimeter from midline. Again, this is for INI-CET NEET PG level. I think FMG students can skip this part. Management of lymph nodes, if it's a small lateral lesion, at least know it is ipsilateral inguinofemoral lymph node dissection. If positive, then we move to the opposite side also, contralateral inguinofemoral lymph node dissection. If it's a midline lesion, that means within 2 centimeters of midline, then we have to go for bilateral inguinofemoral lymph node dissection. Midline lesion within 2 centimeter of midline. Midline lesion would be, see, common sense, they will give you, there is a growth on the clitoris. It's a midline lesion, isn't it? They will tell you it's a, let's say, 3 centimeter, 2 centimeter, more than 2 centimeter growth on the clitoris. Then you deal with the growth and then it's a midline lesion, then you go for the bilateral inguinofemoral lymph node dissection also. So, that's how questions are framed. from this flow chart. If it's advanced stage, please remember it's chemoradiation. Okay. And here remember, obviously it will, advanced stage, we've discussed the staging in brief. Advanced stage will be all the rest, like upper 2/3 of vagina, bladder, rectum. Positive inguinofemoral lymph nodes. Please write down stage 3. This is a direct question they will ask. Positive inguinofemoral lymph nodes. Positive means malignant cells positive, not just enlarged. Positive inguinofemoral lymph nodes is stage 3. Fixed or ulcerated inguinofemoral lymph nodes, pelvic lymph nodes. Remember here, pelvic lymph nodes, distant mets and all, these are stage 4. These are stage 4. This is also question pointer. Pelvic lymph nodes for the rest of the gynae cancer, stage 3. It is reverse here. Inguinofemoral lymph node stage 3 and pelvic lymph node stage 4. Reversed. Keep that in mind. That's how you're going to remember. And let's now come to the last malignancy, quick recall of gestational trophoblastic neoplasia. Now, gestational trophoblastic neoplasia can occur after any pregnancy event, right? But most commonly it occurs after a molar pregnancy event. Okay, and just like, see, it's trophoblastic, right? So the marker is HCG. The marker is HCG. Now there are 4 histological types: invasive mole, choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor, in that order. This is the most common type, invasive mole. Second most common type is choriocarcinoma. What is the difference? Look at this. If you look at histopathology, invasive mole, the villi structure is preserved, but the villi are invading into the myometrium. Okay, so when they invade into the myometrium, more bleeding, and there's also a potential of perforating the uterus also, right? Choriocarcinoma, the villi structure is lost and dimorphic cells are there. Syncytiotrophoblasts, cytotrophoblast, both types of cells, they have neoplastic features, but the villi structure is lost. Placental site trophoblastic tumor and epithelioid trophoblastic tumor, they are very rare. Placental site trophoblastic tumor, at least you should know that the villi structure is lost, that's true. But there is proliferation of monomorphic type of, just one kind of trophoblast cells. Extravillous intermediate trophoblast cells, they become dysplastic. The marker is not HCG. The typical marker is not HCG. It is human placental lactogen and placental alkaline phosphatase. These are direct questions. These are more pathology based. Okay, clear? This sort of histopath diagnosis we could or we could not have while clinically making the diagnosis of gestational trophoblastic neoplasia. We may have this diagnosis, we may not have this diagnosis to begin with. Okay, gestational trophoblastic neoplasia is a malignancy which can be diagnosed even without a histopath diagnosis. We'll come to that. First of all, one-liner pointers. It is the most common GTN if they ask you after a molar pregnancy. Answer is invasive mole. Right? Now, choriocarcinoma develops most commonly after which kind of pregnancy event? See, gestational trophoblastic neoplasia occur after molar pregnancy events. So, after molar pregnancy. But if they ask you GTN after a full-term pregnancy developed in a woman, then it is almost always 99%, almost always a choriocarcinoma. And PSTT, ETT are extremely rare. They always develop after a full-term pregnancy event. So, these are important one-liner pointers. Let's have a look at a question now to understand the clinical situation at hand. Now, 30-year-old woman underwent suction and evacuation for complete molar pregnancy. And you recall that after a molar pregnancy evacuation, weekly follow-up with HCG is done till the levels become negative. Because beta HCG is the marker for just GTN. And the one situation where GTN can occur is after a molar pregnancy. And that is why we are following up after molar pregnancy evacuation. And what better way to follow up than with the beta HCG level, because beta HCG is the marker. Of course, apart from beta HCG markers, there will be symptoms that the patient may have if there is a malignancy developing, gestational trophoblastic neoplasia developing, right? Now, 1 month later, she complains of off and on vaginal bleeding. On per abdomen examination, the size is 16 weeks. The uterus is not shrinking down. It is not involuting. Ultrasound shows bilateral theca lutein cysts. Theca lutein cysts are persisting. They are persisting because of persistent HCG. HCG is causing theca lutein cyst. Beta HCG level is remaining elevated, 1 lakh. On local examination, there is a friable bluish nodule in the anterior vaginal wall. Now look at this. Just a friable bluish nodule in the anterior vaginal wall. This itself, with the clinical background of the patient, where I know this was molar pregnancy evacuation done. And she has a symptomatology also. And there is an evidence of metastasis also. I don't need to wait for HCG levels to, I don't need multiple HCG values. HCG value of 1 lakh is also pretty high. It could have been lower. What I'm trying to tell you is that evidence of metastasis, then you don't need to keep waiting for rising HCG levels or plateauing HCG level. Multiple HCG values are not needed. The moment I see evidence of metastasis, I make the diagnosis of GTN. So she is diagnosed with GTN, true. The primary modality of treatment of GTN, it doesn't matter the age of the woman, let me tell you that. Primary modality of treatment of GTN is chemotherapy. She will need a hysterectomy? No. And all the more reason she is 33-year-old, so that is why also you should think that hysterectomy she may not need. She may respond to chemotherapy. So this is the false statement. Chemo is started, true. Histopath evidence is not necessary to diagnose GTN, true. True, true, true. Histopath diagnosis is one of the criteria of diagnosis of GTN. One should not get tempted to take a biopsy from this friable bluish nodule on the anterior vaginal wall because it will bleed like crazy and it becomes a bleeding that is difficult to control. Choriocarcinoma is a very vascular malignancy. Based on the clinical profile, the diagnosis is fairly certain that it is GTN. Histopath evidence is not necessary to diagnose GTN. This is true. So the false statement here is option number B. She will need a hysterectomy is false statement. So what is the important clinical aspects that you should know? You should know what is the diagnostic criteria for GTN. So when the clinical context is that of molar pregnancy, after a molar pregnancy evacuation, because these are the evacuations we are following up with beta HCG levels, all pregnancy evacuations, all full-term vaginal deliveries, after that we are not doing HCG follow-up, it is only after molar pregnancy evacuation. So in that context, right, clinical presentation is variable. She could have persistent or irregular vaginal bleeding, uterine subinvolution, intraperitoneal bleeding or shock. This would mean invasive mole. That means perforation. Perforation of uterus. Persistent of theca lutein cyst, evidence of metastasis could be there. The entire clinical presentation just we saw in the previous question. But what is the diagnostic criteria? After molar pregnancy evacuation, right, 4 consecutive HCG values showing plateauing. Plateauing is plus minus 10%. 4 values, 1, 2, 3, 4 values meaning over 3 weeks. 3 consecutive values showing rising trend. 3 values meaning 1, 2, 3 values meaning over 2 weeks. Persistence of beta HCG even after 6 months of evacuation, you make the diagnosis of GTN. Okay. Now, histopath diagnosis. When you will have a clinical context of histopath diagnosis, let's say for example, I'll have to give you example. Example, you have a woman with history of abnormal uterine bleeding. And let's say endometrial sampling was done, DNC was done. Okay, there will be some, it's very difficult when there is a history of AUB. That means routine follow-up with beta HCG was not being done. Why? Because maybe the antecedent pregnancy event is not molar. So in that situation, let's say for example, there is a woman, her prior pregnancy is a full-term vaginal delivery or is an abortion or whatever, and now she's having abnormal uterine bleeding, irregular bleeding, whatever pattern of abnormal uterine bleeding, a DNC was done, but she's not relieved. Just this, generally DNC tends to be therapeutic also in abnormal uterine bleeding, if it's because of local endometrial causes or if it's because of anovulatory bleeding. But here in case of GDN, there will be no response to usual treatment. There will be no response to usual treatment. That may be your clue. And then maybe you have ended up doing this DNC and endometrial sampling maybe have been done. And there you have a histopath diagnosis. That is also criteria. And then we have evidence of metastasis with elevated HCG levels. Like I said, she could be having a prior any pregnancy event. Prior any pregnancy event may be there. Okay, maybe prior full-term pregnancy event or prior abortion or prior molar pregnancy. But if you're seeing evidence of metastasis with elevated HCG levels, then you don't need to wait for repeated values of HCG to make the diagnosis. So that is why they ask you what are the sites of metastasis that you are going to look at. That is why it is an important question. So most common site of metastasis is the lungs, then it is the vagina, and then it is the pelvis, liver or brain, least, right? So now, let's say there is a woman with the molar pregnancy evacuation being done, she's being followed up, she has elevated beta HCG and she's complaining of breathlessness, hemoptysis. It's GTN. And like I showed you in the previous question, vaginal deposits. So this is the vaginal mets. Okay, most common route of mets is hematogenous. It is hematogenous. Keep that in mind. Okay, so this image on the right is showing vaginal mets. Please remember, vaginal mets stage 2. Confined to uterus, it began in the uterus, confined to uterus, stage 1. Okay, stage 3, lung mets. Look at this, these are lung mets. Cannonball metastasis. Typical are cannonball metastasis, but there can be miliary deposits also. It's not like always it has to be cannonball, but yes, typically cannonball mets, right? And all other mets are stage 4. So stage 2, stage 3, at least remember this. Okay? Treatment is not decided by staging. Treatment is not decided by this staging. The treatment of choice is chemotherapy. What chemotherapy to give is decided by WHO prognostic scoring system. It is very extensive, it is very exhaustive. Till the FMG level, I think you should remember that what are the 8 features that are seen in this prognostic scoring system. It helps decide the type of chemotherapy to give. However, in INI-CET and in NEET PG, they have asked more of this prognostic scoring system in the sense that they will give you a clinical profile, give you some important pointers and ask you to roughly figure out whether it is a high score or a low score. So you should remember what makes up a high score, right? Like for example, age more than or equal to 40, it is adding 1 score. At least remember term pregnancy is giving score of 2, right? And anything which is more than a year is adding a score of 4. More than 1 lakh HCG is adding a score of 4. So they may say that a woman is diagnosed with GTN after a full-term pregnancy. She's already more than 40 maybe. They may tell you that it has been diagnosed after 12 months of her pregnancy event or after 12 months after her delivery. They may say that her HCG value levels at baseline are 2 lakh or more than 1 lakh basically. Okay. So alone, 4 plus 4 plus 2, this itself makes the score more than 7. So frankly speaking, I remember these high-risk pointers. Obviously, the tumor size has to contribute, the site of mets. See here, lung metastasis alone. The site of metastasis being the lungs does not add to the score. Okay, but the number of metastatic deposits does. And previous failed chemo, right? So remember this broadly. And then they ask you if there is a low score is less than or equal to 6, then we give single agent chemotherapy. The chemotherapy is single agent, but it is given on multiple days. Okay, so the entire cycle of chemotherapy takes the full 1 week, where we give methotrexate intramuscularly. Intramuscularly, methotrexate is the drug of choice. Alternating with methotrexate, then alternating with folinic acid to avoid methotrexate systemic side effects, other systemic side effects. So folinic acid is leucovorin. Remember this. If the score is less, low score. If the total score is high risk score more than or equal to 7, then we have to give multi-agent chemotherapy. And the standard multi-agent chemotherapy is immaco-regime. Okay, immaco-regime is etoposide, methotrexate, actinomycin, cyclophosphamide, and oncovin. Oncovin is vincristine, right? So this is the immaco regime. There's IMA-EP regime also, but this is the standard that you should know the names of these regimens. Okay, and also remember that the role of hysterectomy is limited to situations like if it is a PSTT or an ETT, these type of gestational trophoblastic neoplasias, they don't respond to chemotherapy very well. So there is a role of hysterectomy. Hysterectomy becomes a primary treatment. If it's a perforating invasive mole, then to save the life of the patient, because she will go into shock and she'll have intraperitoneal hemorrhage and bleeding, we'll have no other choice but to go for a hysterectomy, right? So perforating invasive mole, one can start with chemotherapy also, but one may have to end up doing a hysterectomy if the bleeding is uncontrollable. And failed chemotherapy, yes, failed chemotherapy, if you've given a couple of cycles of chemotherapy and then you see that it's not working, then you want to debulk the primary tumor, you need to remove so that the response to chemotherapy is better. Then yes, one thinks of hysterectomy. So primary treatment is chemotherapy. Okay, role of hysterectomy is in certain situations. Okay, so with this we finish off GTN also, and with this we finish off the recall and the discussion, rapid revision on the gynae cancers, and we have touched upon all the major gynae cancers that are needed. Again, like I told you, a lot of focus should be given to cervical cancer and ovarian cancer, and a lot of focus should be given to endometrial cancer till the aspect of diagnosing endometrial cancer. So diagnosis of endometrial cancer will begin from abnormal uterine bleeding in reproductive age group women, ending up with endometrial aspiration, sampling, and indications of hysteroscopy. And diagnosis of endometrial cancer we will end up doing, let's say, in a profile of postmenopausal woman and presenting with postmenopausal bleeding. So the workup till you reach the diagnosis of endometrial cancer, the histology, the basic of staging, that much is good enough. And for the gynae cancers, as far as treatment is concerned, then again I don't think you should waste too much time going in depth into the treatment approaches. But yes, I think for the undergraduate level, it is more about knowing the basics, the workup, the diagnosis, and screening if there is. And screening, you know, the role is in cervical cancer, right? So thank you for this session, and all the best for your upcoming exams.